Morning, everybody. So today we are going to deal with another important topic, that is palliative care in renal diseases. And we are very lucky to have Dr. Frank Brennan with us, and who is a pioneer in renal palliative care. And he is a palliative care physician in Sydney, Australia. And his major interest is in care of patients with end-stage kidney disease and motor neuron disease. And he is the past president of Australian and New Zealand Society of Palliative Medicine. And he is a senior lecturer in the Faculty of Medicine, University of New South Wales. And Frank is also playing another role as a lawyer and has published extensively on human rights, dimensions of pain management, and palliative care. He has published narratives drawn from his work that have been broadcast on Australian national radio. And he has been awarded the honor of Member of Order of Australia for significant services to palliative medicine and to medical education. And recently, he authored 2 books, including Standing on the Platform, Stories and Reflections from Palliative Care. And personally, I have been lucky to attend masterclass in renal palliative care with him in KMC Manipal. And after that, even there was another echo on renal palliative care where I was also a member. And recently, I met him in the IAPC conference in Bangalore. So it is with a great pleasure I am inviting Dr. Frank Brennan to present and take over the session.
Thank you so much. Thank you so much, Dr. Sunil, for that introduction. So I'll just see how we go. I'll try and share the talk. This is going to come up. Now, I'll just check with you, Sunil and Sri. Can you see the opening slide?
Yes. That's
good. And does it move if I move it?
Yes, it's moving.
Perfect. Well, look, welcome everyone to this session, and I very much appreciate the invitation from Dr. Sunil Kumar and the whole of Pallium. So, and I just encourage all of you from all the different countries that you are with this global fellowship series. This is a wonderful opportunity for you to learn as much as you can from the different speakers and hopefully have a good sense of things. So in essence, what this is about is really an alliance between palliative care and nephrology. And I'll talk in more detail about how the whole process started and what's unfolding both in India and internationally. I'm going to start with a case study of a patient that I saw a couple of years ago. She was in a rural area. She was a 53-year-old Aboriginal woman, type 2 diabetes mellitus, hypertension. She had end-stage kidney disease and with diabetic nephropathy, and she'd been on hemodialysis for about 5 years. When I first saw her, she was extremely distressed. She shuffled into the clinic room. Her head was down. There was no eye contact. She described how my legs moved all through the night. So she had severe restless leg syndrome. I itch all the time. Often it becomes ferocious. Notice that language, ferocious in terms of itch. So she had severe uremic pruritus. My feet and calves burn and get pins and needles. It is awful. She had severe diabetic peripheral neuropathy. And sleep, I asked her, she said, I don't sleep. I doze in 5-minute lots. I sit on a chair and put my elbows on my knees to hold them still, and I pray to die. Now, in palliative care, we regularly see patients who are suffering, but this woman was the image of suffering. what possibly could we do for her? And I'll return to her case a little later and explain what I did do. So I suppose the overview of the lecture really is, first of all, why would palliative care have an alliance with nephrology? Or more particularly, why would nephrology need palliative care to help it? In other words, the interface of the two disciplines. I'll talk a little bit about decision-making around dialysis and how complicated that story is around the world. I'll talk about when dialysis is either decided against or simply not available or not affordable, what does the conservative management of kidney failure look like? I'll touch on symptom management in kidney failure. I'll touch on advanced care planning. And I'll touch on the care of the dying renal patient. And then through it, I'll perhaps talk about developments in India and internationally. So what possible role does palliative care have in nephrology, the interface of the two disciplines? This was an important discussion, especially from nephrology as this idea started to come. Some nephrologists said, look, we don't need another discipline. We're doing a fine job. Why would we need palliative care? So that discussion needed to be made over and over again, particularly for nephrologists, to allow them to realise that, yes, palliative care could indeed help their patients. So if you like, this is an image of a painting by an Aboriginal artist from my country. And I put this slide up, or I use this as a teaching tool because it's a metaphor, really. When European settlers first came to this area of Australia, they saw this as godforsaken desert country of no use. And it was only into the 20th century that great artists like this artist started to show the beauty of the country. So the metaphor is looking upon the landscape of a patient with life-limiting illness. Whether it's cancer or kidney disease, cardiac disease, you could look upon their landscape, yes, with an active eye, say with cancer, of course, with chemotherapy, radiotherapy, etc., and with renal disease, with dialysis, transplantation. But you could also look upon them with another eye, and that's the eye of the palliative eye. And you can do that at the same time. It doesn't have to be only active therapy until that's exhausted and then the patient is deteriorating and dying, and then palliative care being involved. So if you were to ask me what is this interface, I suppose in summary, there's 5 separate interfaces or links between nephrology and palliative care. Epidemiology, mortality, morbidity, quality of life, and quality of dying. And I'm going to go through each. Epidemiology. Well, when dialysis first came on the scene, it was seen as a miraculous, and still is, a miraculous technology. And at the beginning, it was reserved for younger, fitter patients. In Western countries, it started to be available over time for every patient, possibly. So this started to change the dynamic. So in developed nations, the mean age of patients commencing what we call renal or kidney replacement therapy, KRT, is about 60 to 65. And the greatest prevalence of patients on dialysis is the 65 to 84-year-old group. So there's more and more discussion in Western countries about so-called geriatric nephrology. And when you think about this particular age group, a lot of other issues in terms of comorbidities for these patients. The other aspect of the change in epidemiology globally is the rise of diabetes mellitus. So the percentage of incident patients with kidney failure that have diabetic nephropathy is over 50%, Singapore, Malaysia, New Zealand. 40 to 50% in many countries. So when you think about that, you also think about the other macro and microvascular complications of diabetes. So what's happening globally? There's probably several stories unfolding internationally. In Nation A, this nation has lots of resources. Dialysis is universally available, and anyone, even elderly, frail patients, could be started on dialysis. Another nation has more limited resources, and dialysis is reserved for younger, fitter patients or simply reserved for those that can afford dialysis. And other nations, poor resources, and dialysis is not available in any way. So throughout the world, therefore, many patients with kidney failure embark on a conservative non-dialysis pathway, not through choice, but simply because dialysis or transplantation is not available or affordable. So this has been the source of a large amount of discussion within nephrology in the last couple of years. How can nephrologists act as nephrologists if dialysis is not available or people cannot afford dialysis? And the answer is they can be involved, but it's going to be in a conservative non-dialysis pathway. What's happening in India? Well, the ISN Global Atlas of Kidney Disease says that it estimated that 7% of the adult population of India has chronic kidney disease. Now, that could be very mild chronic kidney disease. It's only when you get to CKD stage 5 that you're in end-stage kidney disease, if you like. Now, this is interesting. It's 10 years old, but it's written by a very leading Indian nephrologist, and he's talking about the current status of kidney disease in India and Pakistan 10 years ago. According to data from large hospitals, end-stage kidney disease patients primarily attend for diagnosis and receive hemodialysis only for a brief period. It is estimated that most of them discontinue dialysis and die. Gradually, however, patients are being maintained on hemodialysis in increasing numbers. So in the modern era, in the last year or so, there's been a remarkable development with India called the Pradhan Mantri National Dialysis Program, an attempt by the government to make dialysis much more available. So now there's challenges there, of course, in the number of dialysis machines, the number of nephrologists, the number of renal dialysis nurses, let alone the number of palliative care people. So this story is starting to unfold where people who hadn't been on dialysis are more likely to be on dialysis now. So that's epidemiology. What about mortality? If you place anyone on dialysis, does that guarantee them a normal life expectancy? Unfortunately, no. So overall, patients with kidney failure, with or without renal replacement therapy, have a reduced life expectancy compared to those with age-matched controls. In Australia, 65 to 74, the mortality at the end of the first year was 11%. But for those 75 and above, that figure starts to really rise. So this is starting to be equivalent to many malignancies, isn't it? Okay, so we've talked about epidemiology, mortality. Now let's talk about morbidity. Well, this is a big issue. And this particular group are among the most symptomatic of any chronic disease group. And I'll speak to you more detail about that later. Then talk about quality of life. If you start someone on dialysis, do they have a normal life expectancy? Normal quality of life? No. Many studies around the world have shown that patients with who are on dialysis have a reduced life expectancy, reduced quality of life, quality of life. So this is from our studies done over several years, going back now some years. This is a quality of life survey. The top dark line is age-related normals who do not have kidney disease. So those bottom figures you can see over years show a fairly consistent story in terms of reduced quality of life. Now, on the left-hand side of the screen, these are the physical domains. On the right-hand side of the screen is the mental health domains. So as you can see, the physical domains, consistent less quality of life in physical domains, interestingly, less so than mental health domains. And then the quality of dying. Now, I grant that that's not a commonly used expression. What I mean was, how does a patient with kidney failure die? They may die having been on dialysis. They may have died never having been on dialysis. They may die of their underlying kidney disease. They may die of a comorbidity like ischemic heart disease. So it's very varied, if you like. The circumstances vary considerably. If it's an expected death, say after withdrawal from dialysis, the management of the dying phase is crucial. And as we know in palliative care, the manner of that dying will be remembered forever by the family. So it's important we get this right and do our best for these patients. So in summary, these are the 5 interfaces of the 2 disciplines, and these are the very topics there which started the whole process, where a head of department of nephrology was looking at his patients and saying, we have a problem. We have an increasing number of older, frailer patients with the expectation of dialysis, and we don't think everyone should be placed on dialysis. We realise patients do die, of course. We realise they're very symptomatic. We can't seem to shift their quality of life, and we don't do the dying well. You do the dying well. In palliative care, you have the skills. So that's where the overture, the discussion started. Could we start to form an alliance between nephrology and palliative care? And that discussion has been repeated in India and around the world. So the recognition of this interface has over time led to the development of what is now being called kidney supportive care. What is kidney supportive care? Well, it's the holistic, multidisciplinary care of people with chronic disease, especially kidney failure, whether they are receiving kidney replacement therapy or being managed conservatively. I'll let you read that definition. So this is important, isn't it? Because sometimes people think kidney supportive care is only those on a conservative pathway, but in fact it can be for any patient, dialysis, transplantation, or conservative, and it's a holistic, as of course in palliative care, the principle of palliative care. And also we're saying to people, particularly governments around the world, that kidney supportive care should not be seen as an excuse for governments not providing access to dialysis. So the temptation for health departments is to say, oh, you've got kidney supportive care. You don't need any more dialysis machines. Well, actually, no, that's not an excuse. Kidney supportive care is really for the right patient at the right time, and it doesn't take away the need to build up access to dialysis. So things started to move ahead, where there was within nephrology, there were the so-called KDIGO controversies conferences on lots of things, calcium and phosphate, etc. But they decided to have one on supportive care, and this was from around the world, this gathering, including from India. Then in 2018, the International Society of Nephrology, the ISN, hosted a summit on integrated kidney care. This was a major document that came out of this, which actually endorsed the role of renal supportive care. So this was fascinating. This was a declaration from within nephrology, not palliative care knocking on the door saying this might be a good idea. Nephrology saying this is very important here. And kidney or renal supportive care we see as equal to dialysis, transplantation, conservative care. So that was fascinating that nephrology took this in the modern story. Within the International Society of Nephrology, there's currently a kidney supportive care working group, and they're looking at an international definition of kidney supportive care, a curriculum. So when that comes out, watch this space, because that'll be available for everyone. And there is Indian and African and Asian, really from around the world, input into this curricula, and also ideas about how to create and nurture services. Okay, let's move on to the next topic, decision-making around dialysis. So as I've said, kidney failure, EGFR, estimated glomerular filtration rate, if it's less than 15 mils per minute, that's CKD stage 5, and that used to be called end-stage kidney disease, but it's now called kidney failure. Once kidney failure is diagnosed, it is important to examine the various options. So there's really 2 main options. One is renal replacement therapy, and that could be hemodialysis, peritoneal dialysis, transplantation, or conservative management. So it's really comes down to a choice here. But is it a choice? In many countries, it's not a choice, as I said, because people cannot afford dialysis. So what are the important elements in this decision-making around dialysis? So if you're in a situation where you've got dialysis available and you're trying to weigh up whether this particular patient would be get an advantage from dialysis, then there's a couple of things. First of all, survivorship, dialysis versus conservative, health quality of life, hospitalisations, and effect on carers. Now, as doctors, of course, we very much focused on survivorship, but in the last couple of years, there's been more focus also on these other aspects of how the person themselves feel. How do they feel about this? So survivorship. So this particular study was a major study in 2007 by Fliss Murtagh and her group. Fliss Murtagh is a palliative care specialist in the United Kingdom who did her PhD on this topic. And what she did was very interesting. They looked at a group of older patients, 75 and above, with CKD stage 5 kidney failure, some of whom started dialysis, some of whom did not. And they found that the dialysis group had a clear survivorship advantage. However, when they factored in comorbidities, particularly ischemic heart disease, those Kaplan-Meier curves collapsed. So this was the first study that indicated that there may be a group who don't necessarily get a survivorship advantage on dialysis. That is, 75 plus with ischemic heart disease. That study was followed by other studies. This is looking at renal replacement therapy in conservative and aged group, low comorbidity, high comorbidity, and you can see with the high comorbidity, those curves crossing. Carson went one step further and said, okay, you, the older people on dialysis, you're living longer as a group, but how are you spending your time? And approximately 80% of the extra days survived was spent either being on dialysis or being hospitalised for complications of dialysis. And people thought, okay, this group is surviving, but they are very much the patient. This study got a lot of attention from the New England Journal. Now, this was a US nursing home patient starting on dialysis. So you can just imagine this story. So before we go to the graph, have a look at the epidemiology here. So look at this. 2/3 have got diabetes or congestive cardiac failure. So this is a very, very comorbid group. 22% having dementia. So that got a lot of attention in the United States. Why are we starting demented patients on dialysis? Now, it doesn't say the degree of dementia, but inevitably that is also a life-limiting illness, and people are going to be very struggling staying on a dialysis chair. So as you can see, what happened was that over a 12-month period, that there was a significant mortality, and for those who survived, a significant reduction in their performance status, as you can see. So this got a lot of attention, people thinking we need to be very careful about the frailer, older patients starting dialysis. The first study of this kind in the Southern Hemisphere, what we did here in Sydney, and we found that if you're 75 and above with 2 or more comorbidities, one of which was ischemic heart disease or congestive cardiac failure, there was no survivorship advantage. So this started to enter the discussion group. This was an interesting study from Holland, where they found that that survivorship advantage was lost at 80 plus years old, irrespective of your comorbidities. Now, that's just one study. It does need to be repeated, and it's too early to actually make that call universally. Okay, what about the quality of life? Well, we've talked about the quality of life earlier, and as you can see, the decrease in quality of life pretty universally for those on dialysis, and perhaps a little bit less so for those on a conservative pathway. Hospitalisations. Well, in elderly patients, the rates of hospitalisations on dialysis, 20 to 35 days per year, on a conservative pathway, 10 to 16. So that looks to be a difference there. Impact on carers. Now, this is a huge story for carers of dialysis patients, meeting 56 to 70 hours of care per week. All aspects is covered in terms of this, and increasing carer burden with increasing patient age and comorbidities. So this starts to impact on the carer. What guidelines exist for this decision making? Well, this was a major guideline that came out of the United States, and I'll let you read its title. And they said it's reasonable to consider foregoing, in other words, not starting dialysis or even withdrawing dialysis for patients who have a very poor prognosis or for whom dialysis cannot be provided safely. So there's issues of the technical process of dialysis because the second one there, significant hypotension every time you put a person on dialysis is not possible. But also if they've got advanced dementia and they keep pulling at the needles and it's just impossible to keep going. They may have another life-limiting illness like a cancer. In our experience, people with this don't immediately stop dialysis. They keep going until the anorexia, cachexia of the malignancy and the fatigue is such that they say, look, I'm ready now to cease dialysis. But perhaps the most important take-home message there, they talked about in those patients who were 75 and above, stage 5 kidney disease, who met 2 or more of the following statistically significant poor prognostic criteria, it was reasonable to consider. Note the language. They didn't say you shouldn't start dialysis. They said, just think. It is reasonable to consider not starting dialysis where the number one is the surprise question. If you think, honestly, this person might die in the next 12 months. High comorbidity score, particularly ischemic heart disease, impaired functional status, and severe malnutrition. So it's 2 or more of those factors. So this particular slide was starting to be used in many places by nephrologists to assist them in working out whether a particular patient may or may not have a survivorship advantage and moving perhaps towards a conservative pathway. But why is dialysis sometimes commenced when the nephrologist feels it may be futile to do so? Well, I suppose it's the whole question, why do doctors provide futile treatment? It can be that doctors feel they've been trained to treat and they don't want to not treat. They're inexperienced with death and dying, don't want to give up hope, aversion to death, or there's a heavy influence from families or prognostic uncertainty. So some of these comments are interesting. Look, we've been trained to treat, you don't learn, you learn how to treat, and it's easy to treat, much easier than not have these high-level discussions. Patients' families often have unrealistic expectations. The provision of futile treatment will probably come down to how forthright or aggressive the family are, to the doctor's ability to deal with this. So this is really an embattled area. And it may be that you've seen this story in your own hospitals where families can be very, very demanding, if you like, and of course now if it's not possible to offer dialysis, but if it is possible to offer dialysis, then I guess the whole process there starts to turn into a debate. And it may be easier for nephrologists to simply offer dialysis. However, once dialysis is commenced, this immediately raises the challenge of what to do when the patient does not do well on dialysis. Okay, this is really important internationally. What does the conservative non-dialysis management of kidney failure look like? This may be decided in consultation with a nephrologist, perhaps weighing all those things up I've just talked about. The patient was never referred to a nephrologist in the first place, and sometimes people walk around with undiagnosed kidney failure. Or the patient is got kidney failure, but they're unable to have dialysis due to issues of access and affordability. And many, many countries face this story. So what level of care occurs for this group? If it's being raised as an option, what does conservative pathway mean? What's its content, and can we make predictions about the future? So we need to be careful here because we cannot simply abandon these patients. And we cannot simply send everyone off to palliative care because there's not enough of us. And we also don't have renal medicine skills. If dialysis is not being offered, what does conservative care look like? Well, I think it's the best of the 2 disciplines. It's certainly the best of palliative medicine, but it's also the best of renal medicine. What's the best of renal medicine? Well, preserving residual renal function, monitoring blood pressure, calcium phosphate, anemia, and fluid balance, as well as all the very factors we know in palliative care. And so what we're now training our renal trainees is to have all of this together so that they are as good at dealing with calcium phosphate as they are dealing with the care of the dying patient. So bringing these 2 skill sets together, if you like. But it does require the 2 skill sets. It cannot be palliative care alone or primary medicine alone because we don't have the skills of renal medicine. Equally, it cannot be just nephrology because they, as Professor Brown, who came to us, said, we don't have your skills in palliative approach. So there's a modest but growing body of literature of research on this cohort of patients. Survivorship. So let's have a look at survivorship of these patients on a non-dialysis patient pathway. So we did a study here, and from eGFR 16, the median survivorship of these patients on a conservative pathway was 16 months, longer than we really expected. I think when people got to eGFR 10 or 8 or 7, people thought, well, they're about to die, but in fact, many patients live longer than we thought. And 1/3 of non-dialysis patients live more than 12 months after the eGFR fell below 10 mils per minute. And there's some of the other studies around the world. What are their needs? This is another Murtaugh study, a FLIS-Murtaugh study, looking at those on a conservative pathway, looking at 3 outcome measures you can see at the bottom. Well, first of all, the mean age 81, so that's interesting, isn't it? The symptoms, palliative needs, and functional status. And she found that those on a conservative pathway had a Konoski performance scale around about 60 to 70 for some considerable time, but about 2 months before they died, they took to their chair, they took to their bed, and they started to deteriorate. Also, their so-called global distress, their palliative care needs started to increase, and their symptomatology as well. Yes, their performance status, their symptomatology, and their palliative care needs all started to increase about 2 months before death. Now, we found this very useful to show people, because I think that there was a concern within our community palliative care service that as this started, they would be deluged with renal patients. And we said, no, these patients are going to be looked after by nephrology and kidney supportive care. And it may only be really in the last 2 months of their life that we need to involve community palliative care. Let's talk about symptom management. So this is a highly symptomatic group, whether or not you're receiving dialysis. Patients rate symptoms and their management very highly. What are the symptoms of patients? I'm going to show you a graph now with symptoms of dialysis and symptoms of those on a non-dialysis pathway. Now you can see that there's a huge number of symptoms. Also, you can see quite significant prevalence data on those, perhaps those top 4 or 5 symptoms, where a lot of patients are getting these symptoms. And indeed, studies on the dialysis group show that the mean patient, the mean number of symptoms for a patient is about 9 separate symptoms. 9 separate symptoms. Remember that lady that we spoke about at the beginning. So this is a very symptomatic group. Symptom control is challenging. Symptoms interact and compound with each other. So remember that first lady where she had itch, restless legs, and pain, leading to shocking levels of poor sleep and fatigue. So fatigue is complicated. It's not simply this story, but one of the stories, if you can get back to the source of it, deal with the pruritus, the restless legs, and the pain very well, it may well be that the patient is sleeping much, much better. Symptoms may derive from the comorbidities, particularly, well, we talk about diabetes, but lots of other comorbidities, of course. Kidney failure constrains the use of medications. The pharmacology is complex, and the autopharmacokinetics is, there's often a story there. There are multiple gaps in knowledge, and recommendations and published data occasionally conflict, so that makes it more difficult. So I think we come back to our general palliative care principles that you've heard many, many times over. Think of the cause. Why is this person in pain or nausea or itchy? Being meticulous, in other words, realizing that they may have many symptoms, and the principle of non-abandonment, never saying, look, I'm sorry, there's nothing more I can do. Validated symptom instrument. So the 2 main ones used around the world are the IPOS Renal or the ESAS Renal. We use the IPOS, and I'll let you have a look at this. On the left-hand side of the screen are 15 separate physical symptoms. On the right-hand side of the screen includes anxiety and depression, but other psychosocial and spiritual questions. Do you feel at peace, etc., etc. We find this this has been validated for kidney patients. So we find this extremely useful because we get the patient to fill this out, or the relatives, or with an assistant perhaps, or a volunteer, to fill it out in the waiting room. So by the time they come into the clinic room, we can see what's troubling the patient most. And then we can follow the patient over and over again. So every patient at every clinic fills out the so-called IPOS Renal. With notable exceptions, there's little or no evidence, or little evidence on symptom management. So what do? Well, I think we do our best, essentially, but we often extrapolate from the non-renal domain. In terms of the level of evidence, the symptoms fall into several categories. Probably the most studied with the greatest level of evidence is uremic pruritus. There is an international evidence-based guidelines on the management of restless leg syndrome generally. Then we have small bodies of evidence in CKD for depression and taste changes. And then we have little or no evidence in multiple symptoms, including pain, nausea, vomiting, dyspnea, constipation, insomnia. So a lot more needs to be done here. So it's a field wide open for research. Look, I'm not able, of course, time is limited, so I'm not able to go through every symptom, but I might present some representative symptoms. So we're going to talk about these three symptoms: uremic pruritus, restless legs, and pain. Uremic pruritus. So with pruritus, generally, even before we come to uremic pruritus, but there's been a quiet revolution unfolding in the understanding of the basic pathogenesis of pruritus. In the skin, there are nociceptive sensory nerves, and one of the sensations is pruritus. Look at this remarkable photo. It's only about 2 years old. It's from Italy. And this is the skin. The lower part of the slide is the dermis, and the upper part is the epidermis. And the red is these sensory afferent nerve fibers infiltrating deeply into the epidermis, picking up all the sensory changes. The blue is the skin nuclei, skin cell nuclei. It's a remarkable photo and a remarkably beautiful photo, isn't it? So the itch fibers are C and A delta fibers, but I'm going to concentrate on the C fibers. We now know that 5 to 10% are dedicated to itch. For many years, this was the assumption it was all to do with histamine. But look at this remarkable story that started to unfold back in the mid-2000s. The 10% of the itch fibers are histamine dependent, and 90% are histamine independent. So that completely changed everyone's view that yes, histamine is very important, mosquito bites and allergies, but there's this whole wide world of non-histaminergic itch out there, and almost certainly uremic pruritus, cholestatic pruritus are non-histaminergic. So one of the myths is that all itch is histamine mediated, and that the best first-line medication are antihistamines. Now let's turn to pathogenesis of uremic pruritus. Well, we actually don't know. It's obscure. There's lots of different theories, but we don't know for certain. We do know something, though. We do know that the itch fibers that transmit the itch signal in uremic pruritus follow a non-histaminergic pathway to the brain. So this is very important, isn't it? And yet, around the world, antihistamines are constantly used for uremic pruritus, but probably not without basis now. So just in terms of a summary of treatment, we're blessed with this Cochrane review from 2020. And what did they find? Of all the treatments for uremic pruritus, the gabapentinoids, gabapentin and pregabalin, were the most studied and showed the greatest reduction in itch scores. So that's quite a statement, isn't it? There is another class of medicines that are getting a lot of attention called the kappa opioid agonists. They may reduce itch, but indirect comparison suggests a much more modest effect in comparison to the gabapentinoids. The Cochrane review did talk about some evidence for a couple of things there, but there were small studies and more on further investigation. Why might they work? Well, turmeric, interesting turmeric in coumarin and turmeric inhibits production of TNF-alpha and interleukin-6, which almost certainly is part of the uremic pruritus story. Onto oral montelukast, leukotriene receptor antagonist, and leukotriene B4 is a very renowned pruritogen and is almost again certainly part of the uremic pruritic story. And topical capsaicin, as you know, denudes a substance P from those remember those red, beautiful red fibers into the epidermis, and that halts transmission or reduces transmission. So what's our approach? Well, first of all, we ask everyone, are you itchy, at every clinic? And we realise that not every patient with kidney failure with itch has uremic pruritus, because it may be that they've got another itch story going on. Several times we've been caught, we've been assuming the person's got kidney failure and they're itchy. In fact, they're not itchy from uremic pruritus, but they have things like scabies, atopic eczema, psoriasis. So what are the therapies? Now, we've just gone through those therapies, but just in terms of how we organise ourselves, topical preparations, oral medications, and ultraviolet. So topical, what we do is we ask the patient to have some moisturisers. Xerosis or dry skin is very common, while it doesn't cause it can exacerbate. So using things like sorbolene or QV cream is very good. Another non-pharmacological approach is keeping the skin cool, so avoiding hot showers. Also cutting back fingernails, because people can scratch and make it terribly at night because they can get blood on their sheets and things. So all those non-pharmacological approaches, moisturisers, cooling of the skin, cutting back the fingernails. Also non-perfume soap, using goat's milk soap, or even body cleansers. Capsaicin cream, yes, it works, but it's out of the chili family, so it does cause a burning feeling. But we've been actually combining that by a compounding pharmacist with some menthol. So that works on the cold receptors that have an anti-itch effect. So this is an interesting thing. If you get that balance right, the cold of the menthol balances out the heat of the capsaicin. And maybe even adding some lignocaine in there can be very helpful as well. Systemic therapy, well, we've just heard about the gabapentinoids, but we need to be very careful with the dosing. So with a dialysis patient, gabapentin 100 or pregabalin 25 milligrams after each dialysis. So it may be 3 times per week. If they're not on dialysis, eGFR is less than 15, gabapentin 100 or pregabalin 25 milligrams every second night. Now, there's a move internationally to move it to each night. So perhaps just be aware that perhaps there's more recommendations about having it noctate. But I certainly, if the eGFR is very low, say under 5, I'd be moving it to every second night, but each night or every second night. Pregabalin, we've talked about some studies there. And what's our experience over years? Well, we've done this many years and many, many patients, and our prevalence rate are consistent. And what about if we extracted those with severe to overwhelming itch at the first clinic? What happens by their third clinic? So sorry, I'll come back. What happens by the third clinic? There was a significant improvement in their itch by their third clinic. So it perhaps puts pay to that sense that, there's nothing we can do about it. I think those very basic non-pharmacological and basic pharmacological things can be very, very helpful. And was that response sustained over time? And we found that, yes, over time, we were able to hold the itch mostly at bay, coming from severe to overwhelming, and also on the conservative patients as well. Let's talk about restless leg syndrome. So what is this? So this is a story where the patient has a feeling in their legs. They find it very hard to describe, followed by an irresistible urge to move their legs, followed by where they start to move their legs, often without control, made worse by sitting down or lying down, made better by standing up and walking around, usually worse at night, and that there's no other reason. This is dreadful. And as you saw in that first case, how awful it can be. Not all again with the kidney, like the uremic pruritus, we need just to be conscious, because some people say, I've got the restless legs, but in fact they don't. They have other things. They may have things like this. So what I do is I sit back and ask them exactly what are you feeling, and over again they say this in lay language. Of course, they start to describe this, and if they say this and they've got kidney failure, they have restless legs. The associations will clearly sleep disturbance, sleeping during the day, premature. Imagine having this on a dialysis session. So you're just desperately wanting to get up off the chair. Mechanisms not completely understood, but really the mechanism is probably this. This is the basal ganglia. You remember from medical school, of course, the production of dopamine. Now, this is not Parkinson's disease, but it is to do with the production. So this is the normal story, how dopamine is produced and then sent across to the dopamine 2 receptors. But iron is an extremely important part of this. Iron is a cofactor for tyrosine hydroxylase, part of the packaging mechanism of dopamine, and sits inside the dopamine 2 receptor. So the theory is that there's a problem with the transport of iron into the cells. This is brain iron metabolism, not systemic iron. So you may have normal iron studies, but there's an issue of transport of iron into these cells. Why is it so circadian? Well, our entire iron metabolism is circadian. And also this whole area is linked intimately to the hypothalamus that has our circadian clock. So how do we manage? Well, I think the first obvious thing would be to give some dopamine agonists at night, because there's a problem with the manufacture of dopamine at night. Yes, good studies, and there's this particular group of dopamine agonists that we use, the non-ergot dopamine agonists, pamprixol, ropinirole, rotigigene. So just to be aware, it's that group, and avoid there's another group called the ergot dopamine agonists. Avoid that group. So side effects, yes, there are side effects of that, and we could perhaps talk about that later. Gabapentin comes into play here as well, and there's some good evidence for the role of gabapentin in restless legs, and indeed in pregabalin. I won't go through with these in detail, but these studies show efficacy for pregabalin, the good efficacy for pregabalin. Interestingly, opioids, and a major study done, it seems to be that opioids have a protective effect on dopamine cells that have been subject to iron deficit. So this study showed the oxycodone stroke naloxone showed to be very useful there. I tend not to use opioids because I tend to use the gabapentinoids or the dopamine agonists. Methadone, interestingly, now methadone is a very interesting medicine because it's not dialyzed and it's mainly fecally excreted, so it's safe in kidney disease, but it does require quite specific skills to use it, but some evidence there for restless legs. Iron infusion, there's a temporary benefit, and also intradialytic exercise, putting pedals at the base of the dialysis chair so the person can move their legs, and that can be very useful. So what do the international guidelines show? Well, they actually favour gabapentinoids as the first-line treatment, are effective and have little risk of a particular complication called augmentation. If dopamine drugs are elected to be treated, then starting low as possible. Other medications to consider, they said, are opioids, including oxycodone and methadone. Okay, and we'll return to that, the whole story, restless legs, a little bit later. But just in summary, it's a feared, not a feared, well, it is a feared, it's a very, a great source of suffering for patients. Often patients come undiagnosed to us and they don't understand what this is, and then bit by bit we explain it to them. It can be treated. It's not that there's no treatment for it. And the international guidelines talk about the initial role of gabapentinoids in those doses we talked about. What about pain? Well, kidney failure and its treatment so there's three main causes of pain: kidney failure, its treatment, and comorbidities. Pain may be related to the underlying kidney disease. So it could be polycystic kidney disease, which is really difficult. That can push up on the into the viscera and down into the lumbar vertebra. Renal bone disease, amyloid, setting off carpal tunnel syndrome, and calciphylaxis, which is, we could perhaps talk about that in question time, a feared and very, very painful complication, very unusual. It's not a common complication of kidney disease. Then, of course, you can have secondary to the treatment, peritoneal disease or Steele syndrome, where you've got the fistula in the fistula for the dialysis in the arm, and there's not quite enough circulation into the fingers, so ischemic pain, cramps, intradialytic headaches. And then you've got a wide range, of course, of comorbidities which can cause pain. So patients can have lots and lots of different reasons for pain. And the patient with pain of multiple causality. So I think that there is an etiquette really of all of our patients, given the prevalence of pain in these patients, inquiring regularly, responding compassionately, treating competently, and referring wisely. And really this is perhaps focused on nephrologists, where they may be struggling to say, look, it's time now, I think you got a pain medicine doctor, palliative medicine doctor, some other person to try and help you with this pain management. So what's towards a strategic approach? Look, there's lack of direct evidence in this cohort. There is a maturing understanding of the basic pathophysiology of pain. So we actually know, of course, about the nociceptive and neuropathic. So this story then is a stepwise approach. And this is actually drawn from a major, probably the most accomplished, if you like, or brilliant study and analysis of pain and CKD written by Sarah Davidson. So her approach is to do the following, simply to say, at the bedside, is this particular pain nociceptive or neuropathic? Because her concern was that everyone was being placed on opioids, perhaps inappropriately, particularly for neuropathic pain. So she talked about nociceptive, neuropathic pain, and going down those basic things that look very similar to you, very familiar to you. The acetaminophen is paracetamol. Note that we're not using morphine because morphine is broken down in the liver into metabolites that are built up and quickly cause toxicity. However, there are many countries that say we only have morphine, we don't have hydromorphone, we don't have these other strong opioids. So morphine can be used, but small dosing widely apart. Not fourth hourly, potentially sixth hourly, eighth hourly, or 12th hourly apart, and small doses to try and avoid toxicity. Example of this approach would be a diabetic peripheral neuropathy patient. Look, there's almost no studies done on this particular group in CKD. We do know the pain is neuropathic. And we do know that, as Sarah said, we go down the anti-neuropathic pain agents. And that's hopefully to good effect. So what are we going to do for Our Lady? Remember Our Lady at the start with the shocking levels of those symptoms. So what I did was talk to her about one medicine. I said, look, there is one medicine that I think, and she said, that doesn't make any sense, doctor, one medicine, all these things is happening to me. I said, yes. So we chose gabapentin. Now, gabapentin is now, the gabapentinoids are now first line now for uremic pruritus, Cochrane review, first line for restless leg syndrome, international guidelines, or internationally, they're first line generally for diabetic peripheral neuropathy. So the gabapentinoids are extremely useful here for 3 separate symptoms. And hopefully we're going to improve her sleep. So I started her on 200 milligrams. Now, why did I break my rule, usually 100 mil? Well, partly because she was so much younger than many of my patients. And also her symptoms were so egregious, so shocking that I thought, okay, well, why don't we get in with a solid dose? We can always reduce the dose, but see if that helped. So she was from a country town. I rang that dialysis unit 9 days later, and they said that all the symptoms had disappeared, and with a markedly improved sleeping the best I have for a long time. So that's remarkable, isn't it? How knowing now, had I met her a couple of years before, I will have struggled. But here, because I've gained such confidence in using the gabapentinoids in this category of patients, that I was confident that things will be much better. There's an issue here in compartmentalizing symptoms, because we can often think, okay, this is pain, this is nausea, this is shortness of breath. But I'll just give you an example. This was a home hemodialysis patient. His main symptom was increasing nausea. We commenced him on metoclopramide. Okay, he said, that's great, doctor. My nausea is much better, but by the way, my legs keep moving at night. So suddenly, by using metoclopramide, a dopamine antagonist, we had stumbled into triggering restless leg syndrome for the first time. So if someone's got restless leg syndrome and nausea, I'll always ask them, I'm not going to start them on metoclopramide or haloperidol. I'll start them on domperidone or motilium, you might know it that way, because that's barely going to pass, or cyclosine potentially. But I'm very careful now of realizing I need to look on all angles of this patient, not just simply one symptom, because you can make a problem there. To what extent can these symptoms be managed successfully? So this was a study done locally on symptom management of dialysis patient, and it was over a 7-year period using the IPOS Renal. And the patients who were rating symptoms very severe, insomnia, pain, lack of energy, poor mobility. And so over time, there was a significant improvement in the combined physical and emotional symptom scores. And the greatest improvement occurred in the 5 most severe symptoms. So that's very reassuring, isn't it? So I think gone are the days when people say, look, there's nothing we can do for these patients. No. If you're very meticulous, you can create a lot of benefit for these patients. Follow up up to final clinic visit median 13 months showed sustained reduction in mean combined physical and emotional scores. These changes occurred without changes in dialysis delivery. What's the evidence for the non-dialysis group? So this was this particular study that we also conducted for the non-dialysis patients. And so we followed them and looked at their symptomatology, and over 6 and then at 12 months, you can see either stable or improved symptoms for the not for dialysis group. And indeed, about 75% were either improved or stable by 12 months. So that's very interesting. Advanced care planning, we do not have time, and I'm happy to speak in the question time, but just to be aware that that's a real story in nephrology because of the nature of these patients in terms of the prospect of deterioration and dying. Care of the dying patient, as I said, we can be extremely helpful to the nephrologists in these patients because in palliative care, we've got great skills in caring for the dying. There are particular issues in kidney patients, such as the story of uremic encephalopathy, where the patient starts to go into deeper and deeper sleep. They may get uremic jerks, maybe even occasional seizure. So you have to be conscious of that. Also, secretions may or may not be a story. Fluid overload is pretty uncommon. People worry and fear about that, but particularly if you're not actually giving parenteral fluids, yes, that'll risk giving fluid overload. But if you don't do that and simply keeping the mouth moist, that's good. They may start to become itchy and other symptoms as well, just to be aware of that. Also, just to be aware, if a patient withdraws from dialysis, there are 2 groups. One, if you're anuric, completely without urine, your survivorship is about 7 to 10 days. However, if you're still passing urine, you may live for weeks or even months, and that can surprise everyone. I'm just conscious of time. Yes, it's coming up to the hour now. I'm happy to stop there, and perhaps we can then turn to questions. The remaining slides were basically looking at how to set up kidney supportive care clinics and what to do. And I'm happy to speak to that, of course, but I might pass back to Sunil now.
Thank you, Frank. And we had a variety of a lot of subjects, topics on renal supportive care, starting from epidemiology and to the end of life care. So we know that many patients suffers from various symptoms, and when we manage pain, there are many issues for us because we do not have the renally safe opioids, but we have methadone is available, but not for all. But mostly available one is morphine. So we have to live with morphine. So even I have used morphine in very small doses, and gabapentinoids, as Frank told, is a very good medication. And I personally have had an experience with the father of one of my staff who had CKD, and his pain, not pain, the itching was relieved with gabapentin. And he also had a breathlessness, which was relieved with very small doses of morphine. So, if, as Frank said, if we can meticulously look into the problems of the patient, then we will be able to do something to relieve the suffering of the patients and families affected with chronic kidney disease. I think I will open the session for discussion now.
So in anuric patients, towards last 7 days, as you said, before they pass out, how do you manage the symptoms with acute dyspnea, fluid overload, and pain?
Yes. So this, this is really important, isn't it? Because this may be the last 7 days, or this, is the last 7 days of their life. So we've just really got to do our best here. First of all, non-abandonment. So of course, we're not going to, in palliative care, we're stepping forward into this area and reassuring patients and certainly relatives that we will try and do our best for them. First of all, I reassure the patient at the beginning that some patients feel if they stop dialysis today, then tomorrow they're in a coma. Well, no, there's going to be some days where you'll have a chance to say goodbye to your family and to do this. I will say to them that over time you will become more sleepy. You'll start to get this uremic encephalopathy, and say to the family they may start to get some jerks. Seizures not very common. And then I would say, as you've just indicated, that we need to monitor all the symptomatology. It may be very quiet without symptoms, or it may be very strong. We just, in terms of the fluid overload, we don't see that too much, except if the patient is been perhaps poorly dialysed leading up to this story, and they've already got fluid overload leading into this story, or they're drinking, way beyond what the recommendations are, or so if. What we tend to do at this particular point, I'll ask the nephrologist to guide me in terms of the use of diuretics, oral diuretics, while the patient is able to swallow. We may sometimes use some subcut furosemide, and then also concentrate on the standard treatment for shortness of breath, small dose opioids, the small dose benzodiazepines, and the handheld fan, or having the fan near them. It's not common, but it certainly can occur and can be distressing. In the midst of all this, yes, suddenly they may start to get itchy or nauseated and things, and we do our best moving from oral to subcut, or sort of parenteral medications, where depending on where the patient is. I'm very conscious that I don't want to suddenly set off restless legs, so I may not use Maxilon or haloperidol. I might use things like cyclosine if I can, or I could use Maxilon haloperidol, but just conscious that it may be difficult. With pain, okay, so this is also going to be a story there, is trying to follow through from before the withdrawal, what's going on, what's needed, and trying to, now that of course, just like with any patient, we may be moving to subcut analgesia or transdermal there. Yes. One of the fascinating things I found when I started, people said, don't worry about this group because uremic death is a gentle death. Well, it may or may not be a gentle death. We can't guarantee that because of the sheer number of symptoms that may come through. So I've learned to be quite vigilant and trying to predict ahead, and trying to use, standard doses of midazolam for agitation, some opioids, subcut opioids, and then whatever you would normally use for secretions. Yeah.
So would furosemide help in these patients with anuria?
Sorry, could furosemide help?
The last 6, the furosemide, the diuretics, will it help in patients with anuria?
I think it just gets less and less, because even though the nephrologists say, oh yes, they lift up the doses to quite significant oral doses, but I think even they recognise in this context that there's going to be less and less effect. Because the kidney's shutting down completely. So it's, I don't think it probably has much of an effect. So it's probably, I think you're coming down to very much the management of the dyspnea.
Thank you, sir.
And also, I guess you're saved because the person is getting less and less interested in food and fluid. So they're actually they're not in a situation where they're drinking large numbers of amount of fluid at all. No.
That is the connected question in the chat by Parul. She's asking whether BiPAP is advisable for fluid overload.
Now, you might need to repeat that question. Was the question about BiPAP?
Yeah. BiPAP for fluid overload. Is it advisable?
We tend not to use it. No, I think, now this is the context of the dying patient. Is that the question from the dying patient? Would you use BiPAP?
No, sir, for the dialysis.
Parul, we cannot hear you.
Sir, for dialysis patients, I'm asking.
Dialysis patients, would you put them on BiPAP? Look, I guess it's just a question of whether that's going to be of benefit to them or not. That often is a question there for the nephrologists and the respiratory physicians to work out. But I guess perhaps the question you're thinking of there, or maybe thinking about, is fluid overload in a dialysis patient. Is that what you're thinking? Okay, now I understand. Okay, so in that context, we really try and work out what's actually going on here. Is this person significantly over taking so much liquid in, way in excess of what's been recommended? So, and it may be that they're just so thirsty they're doing it. Also, we also be very careful about the amount of salt they're taking, because people can take extra amounts of salt and suddenly they get extremely thirsty. So that's a story. But yes, it can be in an extreme situation where the person's now arriving in casualty, fluid overloaded, they may have it. Or the other aspect, of course, is dialyzing them more to get a lot of this fluid off now as quickly as possible. So there's various routes, but I would certainly be looking very carefully at what fluid restriction the person's on. Sometimes they're not on one, and they probably do need to be one on, and also exactly what's happening in their diet with salt intake.
So Frank, another question is, what are the special palliative care needs for post-renal transplantation patients, both failed and successful transplants in the long run? That's by Dr. Punita.
Yeah, that's a really good question. So when I started, naively, I thought, well, transplantations are going to be they're fine because they've got a transplant. That's all right. But then I started to realize, oh my goodness, the transplant patients can be really suffering. So I guess there's a couple of things. One is symptomatology. Now, their symptoms start to shift quite a bit. So they're getting less uremic pruritus, less of quite a few symptoms, but they certainly can get a lot of symptoms. The second story with that is that they get allograft failure, so that their transplanted kidney is starting to fail over time, and they may be becoming more symptomatic, and they may be looking towards coming back onto dialysis or even a second transplant. The other aspect is, because the transplant patients are on immunosuppressives, they are very vulnerable to significant infections and complicated infections, and also they have a higher risk of malignancies, particularly squamous cell cancers, and what they call post-transplant lymphoproliferative cancers. Now, what happens, and I've seen this several times, is that these are like runaway trains. These cancers can just burst out and be incredibly aggressive, partly because, or mainly because, the immune system is being suppressed to protect that transplanted kidney. So there's a challenge there for everyone trying to work out how much immunosuppressives, chemotherapy. I mean, it's quite the complicated story, and our skills really come to pay there, have benefit there in terms of the symptom management. So there's quite a few stories there, and in the midst of this, the psychosocial sense of people saying, no, I don't want to have anything to do with palliative care because I trust this transplant. I'm only believing in the transplant. I don't even think I'm going to die. So that makes it quite a challenge as well.
Any more questions?
Okay, so this is interesting. This question, should we follow protein restriction in diet even for palliative patients? Look, I think that there's been, in the modern era now, much more relaxation of this really in all patients, but certainly in the conservative group, because this is it's a balance really between benefit and burden, and it can be. Some regimes are incredibly strict to the point where the patient just says, I can't do this, in terms of nutritional restrictions. So the renal dietitian that I work with is much more open to a more gentle approach, less restrictive. But of course, that might be controversial. So that might be something to discuss with your renal dietitians to see what they think. They may have a more strict view, or they may have a more liberal view. But it's just a question of discussing with the patients, with the renal dietitians.
She's also asking to comment on fluid restriction at EOS, end of life.
Okay, so I guess we've covered that mostly. Before the end of life conversation, of course, Lasix can be used, though, as the doctor said, as the kidney function worsens, becomes less and less and less, often the nephrologists need to use larger and larger doses of Lasix to make any change. In the dying phase, there's probably, I did talk about the use of subcut Lasix, but I think the kidney is in such a limited status here that it's probably not going to respond too much. And so there, it's simply keeping the mouth moist and dealing with shortness of breath if it occurs. We don't often see it, but if it does occur, dealing with that shortness of breath then. I might ask people, have they witnessed that story of a renal patient with fluid overload dying? Has that been something that they've witnessed?
Yes, I have it.
And how is it managed?
When I saw her, she was actually a cancer patient who was on chemotherapy, and then her kidneys failed. And at that time, she was on IV fluids, and then accumulated. She went into renal shutdown. That was when I tried Lasix, and it was not working because she went into total renal shutdown. So all I had to do was to support her and to keep her sedated, so that she will not feel dyspneic, and just support her with a little bit of oxygen. And that's it. In fact, she had oozing from the skin because the skin was actually bursting out with fluid. We couldn't do anything at that stage, but she passed away peacefully.
Yes, no, that's wonderful. You were able to intervene in that way for her comfort.
Yeah.
Oh, okay. So this is an interesting question. Where could we go for more resources? So what I'll do then is to send through to Sunil perhaps the leading articles in this area that might be useful for you. Also, now, and I didn't get to that slide, I think it's about 2 years ago now, the Indian Journal of Palliative Care had a supplement on kidney supportive care. The entire supplement was on that. So I would go to that. One of the main organisers of that was Dr. Nandini Valath. You probably know her. She's a PalCare consultant she was in Mumbai, she's in Bangalore. But that was a fascinating combination of renal nephrology and PalCare doing that. And also there's currently an iEcho masterclass series that has been run in conjunction with the Indian Association of Palliative Care and Nephrology. They're doing that, and also Nandini's part of that as well, or one of the organisers of that. So if you're aware of that, keep going and listening, because there's a whole series now of masterclass lectures on kidney supportive care. Yes. Also, Dr. Anunja Damani, who's a PAL care specialist in Manipal. That's somebody else you could contact.
Any more questions? Frank, I think it's our duty to relieve you as early as possible because it's only with your commitment you are still awake and giving this lecture at probably now it is 12:30 or early morning in Sydney. So I think we have to give him a big salute for doing this at this time. So
No,
thank you.
thank you so much.
It's wonderful lecture, and I know, and from many of the speakers I have had, he's one of the best who can speak about renal palliative care. And he I think he's the one person who actually brought renal palliative care in India with the masterclass in KMC, and from there the movement started, and now it's gradually spreading all over India. So thank you, Frank, for considering us Indians, because you see people in India is humans and human body, etc. So thank you for all that you have been doing. Thank you.
Oh, thank you, Dr. Sunil. That's lovely. And it's been lovely to meet everyone virtually, and good luck with this whole process of this global fellowship and also your work. And I hope everything goes very well for you all. Thank you. It's been lovely to meet you all.
Thank you, Dr. Frank. I am a non-medical person, but the fact that you agreed to take this session for us without any hesitation, without requesting to change the timing to your suit, proves that you are indeed a great ambassador for us to make a role model. Thank you so much. And I believe everyone here has been got motivated for the day because of you. Thank you for joining, and we look forward to have wonderful sessions like this with you in future as well. Thank you everyone for joining in, and we'll see you in the next session with another interesting topic and yet another eminent faculty. Till then, everyone, take care. Bye-bye.
Bye-bye.